Hello guys, welcome back to A to Z Dentistry, a channel which features easy explanation of various dentist related topics, mnemonics, SAQs and LAQs. So our today's topics is methods for hemostasis. So without any further delay, let's get started. So today we'll be looking at various methods to control hemostasis under the following heads. Firstly, we'll look into the introduction, followed by definition of hemostasis, then methods of achieving hemostasis. Under methods of achieving hemostasis, we'll be looking at mechanical methods, chemical methods and various thermal agents to control hemostasis. So let's move further. So let's try to understand this topic. So what happens when there is a tissue injury? You might all have observed that whenever there is any kind of injury, be it small, be it a large one, it leads to extravasation of the blood. Whenever there is even a small prick in your finger, the first response which occurs is that there is extravasation of the blood, right? And as a natural tendency of the body, our body tries to seize the blood flow, right? It tries to stem the bleed by initiating various steps. That is what we called our coagulation cascade. So firstly, there is vasoconstriction. All the blood vessels, they immediately get constricted to prevent further loss of the blood. Then there is primary hemostasis. Now primary hemostasis is due to formation of the platelet plug. Then we have secondary hemostasis. It is due to initiation of our coagulation cascade. And then we have our tertiary hemostasis. It is due to the consolidation of the fibrin clot, right? So in this picture we can see that the first response whenever there is vessel injury is vasoconstriction, followed by primary hemostasis, wherein there is establishment of a platelet plug, and then under secondary and tertiary hemostasis we have a consolidation of the fibrin clot, right? So basically 4 steps in initiating the process of coagulation. So according to the definition, hemostasis is basically a spontaneous arrest or cessation of bleeding. So now we'll be discussing about various methods for achieving hemostasis or cessation of the blood under the following subheads. Firstly, we'll look at the mechanical methods, then we'll look at certain chemicals, that is chemical methods, and thirdly we'll look at certain thermal agents. So under mechanical methods, the most common type of method is the pressure method. Now under pressure method, what we do is, using firm pressure, we are applying a force onto the bleeding side, either using our fingers or using a gauze for at least 5 minutes. Right now this is again a very common practice in our operatory as well. Whenever there is an extraction, we ask the patient to chew over the gauze piece for at least 5 minutes so that there is control and hemostasis is achieved, right? Now this kind of method mostly controls hemorrhages by counteracting the hydrostatic pressure of the blood vessel itself, right? So by applying pressure, we are counteracting the hydrostatic pressure which is present within the blood vessels, and by this thing we are achieving hemostasis. Then second mechanical method is by using a hemostat. Right now what does this do is that whenever we apply hemostat at the bleeding point, it helps in direct occlusion of the blood vessels. We are directly occluding the blood vessels which are responsible for the bleeding at that site, and in this way we are achieving hemostasis. Then we have sutures as well as ligation, right? So by means of sutures, we can either use absorbable or non-absorbable sutures. We are bringing two severed ends together, right? So we are getting a wound closure and it is preventing hemostasis. Or if we are using the method of ligation, we are tying the severed blood vessels with the help of ligatures to prevent the blood flow. Moving on towards our chemical methods. In this we have adrenaline. Definitely we all must have used it in our operatory, right? So adrenaline, as we all know, that is a very potent vasoconstrictor, right? It has ability to cause immediate vasoconstriction. Now adrenaline is basically available in various ampules, right? And it is applied with the help of a gauze. The concentration which we routinely use for achieving hemostasis is 1:10,000, right? Now we can use this directly by soaking a gauze filled with adrenaline and applying the gauze directly onto the bleeding site. It will prevent the oozing of the blood at that site. So again a very easy method to achieve hemostasis. Under chemical methods, next we have thrombin. Now thrombin helps in converting fibrinogen into a fibrin clot, and as we know that fibrin clot is a more stable, right? So because of its stability, it leads to hemostasis. So thrombin is available in topical form, here you can see, right? So it can be again directly applied into the oozing site and we can achieve hemostasis. Moving on towards our next chemical method to achieve hemostasis, we have Surgisil. So the Surgisil is routinely used nowadays, right? So Surgisil was initially introduced in the year 1940 and it was introduced as an oxidized cellular polymer, right? And it is basically obtained by dissolving pure alpha kind of cellulose in an alkaline solution. So it is basically an oxidized form of cellulose, and as we know that cellulose is a polymer, right? So basically its mechanism of action is that it acts by formation of certain acid products, and these acid products are formed because of the partial dissolution, right? Which whenever we are applying Surgisil over something, there is a partial dissolution of that membrane, and that leads to formation of certain acidic products which are responsible for coagulation of the plasma proteins. Now when these plasma proteins get coagulated, they form a black to brownish type of a gelatinous substance which is very sticky, right? It is a very sticky black to brownish kind of a gelatinous clot which this Surgisil initiates, right? Now whenever we apply this Surgisil, we need to remember that it is a kind of a resorbable material, so it will get resorbed within 4 to 8 weeks from the site. The only disadvantage with Surgisil is that the surgical clot which is being formed here is not forming due to any physiological mechanism. Basically we are using artificial means so that we can have a platelet clot there, right? So that is only a drawback of Surgisil. So here this is how Surgisil looks like. Okay, it almost resembles our gauze piece. So whenever we are applying this, it will lead to coagulation of plasma proteins resulting in formation of a clot. Here in craniofacial surgeries, Surgisil is being applied here. Can you appreciate? This one is the Surgisil. I'll just highlight it. This is our Surgisil and this is the brown clot, right? Now this brown clot is formed because of the reaction of the plasma proteins with the acidic products which are released from the Surgisil membrane. Next we have fibrillar Surgisil, right? So basically it is a kind of modified Surgisil, right, in which there is presence of layers. Now these layers can be adapted to irregular surfaces as well as in inaccessible areas. So this is the advantage with fibrillar Surgisil. As it comes in layers, we can easily adapt this onto irregular surfaces, and complete resorption time is also less. For normal Surgisil, it ranges between 2 to 4 weeks. For Surgisil fibrillar, it is only 2 weeks. Next we have Oxysil. So basically this Oxysil is an oxidized cellular polymer, right? It is a product of an oxidized cellulose polymer. Now this is an absorbable hemostatic material like Surgisil, and it is manufactured by controlled oxidation of cellulose using nitrous dioxide. Now this cytotoxic acid which is present in the Oxysil has affinity for hemoglobin. Now as these have affinity for hemoglobin, they will bind with the hemoglobin present in the RBCs, and this will lead to formation of an artificial clot. As we have previously studied in Surgisil part, that it is the acids which are released from the Surgisil and then the plasma proteins are here getting coagulated in this Oxysil. As this Oxysil has direct affinity towards the hemoglobin, it will attract hemoglobin molecules resulting in formation of an artificial clot. Now the only thing to remember here is that this Oxysil needs to be applied on dry surface, right? As the acid which will get formed when the surface is wet, if at all we are using this on wet surface, right, it will lead to inactivation of the thrombin. So we have to remember that we have to apply this on the dry surface, right? Now the platelets plug into the meshwork which is formed by this Oxysil, and this helps in the formation of clot. In addition to this, as itself this Oxysil is creating a mass, it enhances the process of coagulation. Then one more advantage is that oxysil has bacteriostatic property because it has a very low pH. And again, because of this low pH, the bacteria proteins are getting deactivated and denatured, and this make the bacteria more sensitive towards the antibiotics. So again, there are three advantages associated with oxysil. First, it is resorbable. Then another advantage is because of its alkaline pH, it might result in denaturation and deactivation of the bacteria, and it will make them more sensitive towards antibiotics, and also the alkaline property will lead to bacteriostatic effects. Then again, oxysil is a very common type of hemostat which we are using after extraction. Why? Because it attaches to the bone very easily within the extraction socket, and because it is directly attached to the bone, again it is serving two mechanisms. It is preventing the excessive bleeding, as well as it is generating a kind of a pressure over that particular area and preventing further oozing of the blood, right? So it is available in two forms, either in the gauze form or in the pellet form. The Surgisil is only available in the gauze form. Now one more thing is that this oxysil is available the oxysil is composed of a hollow kind of fibers, right? In Surgisil, there are very solid fibers, they are not at all hollow, right? But in this oxysil, there are very hollow fibers, and these are arranged in a twisted tubal type of a manner, right? Whereas in case of Surgisil, the fibers are very irregularly shaped solid fibers. So again, we have an advantage here. This can surely be a bit lighter in weight, so it may what it will do is that it will be more comfortable for the patient to keep it for extended periods of time. If it gets too heavy, the patient might not be able to tolerate it, especially when we are using this at an extraction site. Moving further, we have gelatin sponge, also known as gel foam or Surgi foam. So previously we'll discuss about Surgi seal, right? Now here we are dealing with Surgi foam. So you need not get confused. As the name indicates, in Surgisil, we had something which resembled more like a gauze, a single membrane, oxidized cellulose polymer membrane. Here we are having a foam-like thing, right? A foam-like piece of material. Therefore, the name foam. So it is jellofoam. So basically, this jellofoam is manufactured from purified pork skin gelatin. It is non-antigenic, and this also is a completely resorbable material. Now this Surgi foam has an advantage that it is able to absorb blood more, right? So it has a average value is that it is able to absorb 45 times its weight in the blood. So a very heavy duty kind of a hemostat here. So it resorbs completely within a period of 1 month to 1.5 months. So again, the resorption period is also tolerable. So at the sites where we are getting very heavy bleeding, or we are unable to achieve hemostasis by using other methods, especially mechanical methods, we can go with jellofoam. Next we have microfibrillar collagen, also known as avitine. So this type of collagen is derived again from the bovine skin, and it may cause contact activation in addition to direct platelet aggregation at that site, right? So in spite of its advantages causing minimal swelling, what it does that it reduces the platelet count drastically, right? So therefore this microfibrillar collagen is ineffective in cases of thrombocytopenia, and its absorption time is also a bit more. It is about 3 months. So at the sites where we need to have a wound closure for longer periods of time, right, to achieve proper union between the edges, we can use microfibrillar collagen. But then again, this is contraindicated in cases or in patients with thrombocytopenia. Next up we have fibrin glue. So fibrin glue basically is a biological adhesive, and it contains thrombin, fibrinogen, factor 7 and apotenin as well. Okay, so this is fibrin glue. As we can see in picture B, this is an open wound, and here with the help of a syringe we are injecting our fibrin glue. In picture C, we can see a very sticky gelatinous kind of thing over the wound. This is our fibrin glue, and then we are giving the dressing to the patient. So this is again a very simple method to achieve hemostasis. We can directly use this fibrin glue onto the site where bleeding is present, and we can achieve hemostasis. Next, we have streptics and astringents. So these are the agents which basically act by precipitation of protein, and by this process this leads to cessation of the bleeding, right? So commonly used streptics are basically Monsell solution. Now this Monsell solution basically contains ferric sulfate as well as tannic acid. So basically it's a mixture, but predominantly it contains ferric sulfate. And also an example under this category is thrombin and gelatin sponges. So this ferric acid is a very powerful kind of streptics, and it was more commonly used in earlier days. Tannic acid is again an astringent. So these are not routinely practiced now, but it was a very common thing back then. Next up we have alginic acid. So this is basically available in a powdered form, right, and special packages, and these weigh about 5 mg, right. So it is placed directly over the bleeding site. It forms a protective film, right, and this film basically presses or compresses the capillaries and stabilizes the blood clot in place. So alginic acid, again a very easy method to achieve hemostasis. Our next hemostatic agent is natural collagen sponge. So basically it is a white spongy material. It is non-antigenic, and again it is a fully resorbable material. Basically it acts by stimulating the platelet aggregation, right. So it activates the coagulation factor 11 as well as factor 13. So it is basically preferred in patients wherein the patients are more susceptible towards hemorrhage, especially after certain dental procedures. For example, patients with hemophilia, right. So these kind of patients wherein already we are expecting increased amount of blood flow, even from minor cuts or minor usage of our surgical instruments. In that cases we can use natural collagen sponge. Next is fibrin sponge. So again this is also non-antigenic, but this is obtained from bovine material. It is treated with certain chemical agents in order to avoid any allergic reaction or antigen antibody reactions. Now it is applied directly onto the bleeding site, and this is again very commonly used in post extraction socket. It acts by stimulating the formation of a normal clot, and it also forms a temporary plug, right. So it is basically forming a plug over the small injured blood vessels, and therefore it is controlling the bleeding at that side. Now again it is also fully resorbable, and it will resorb within a period of 4 to 6 weeks. So again very good material for post extraction sockets. Next up we have bone wax. So basically it is a sterile and non-absorbable type of a material, and it is basically obtained by mixing various types of waxes together. So it consists of 7 parts by weight of wax, that is it can be wax derived from white bees or our synthetic paraffin wax, and 2 parts of olive oil, and apart from it, it also contains 1 part of phenol. It is available in white, and also it is available as a solid rectangular plate, right. So it is indicated in cases wherein there is bleeding from the bone or there is bleeding from chipped edges of the bone. As the name itself indicates, it is mainly used to cease bleeding from bony sides, right. So this bone wax is softened with the help of fingers to desirable consistency, and it is directly applied onto the bleeding site. So basically the mechanism by which it is acting is that it is causing a mechanical obstruction of the osseous cavity containing the blood vessels, and therefore it is acting as a temporary obstruction to those small and minute vessels and preventing oozing at that particular site. So if at all we are using this wax very frequently, it may lead to formation of a wax granuloma. Basically, as it is non-resorbable kind of a thing, it may lead to a foreign body reaction, and that thing is known as wax granuloma. Next up we have a recently introduced hemostatic agent, that is Austine. Now it is made up of a water soluble alkaline oxide copolymers, right. So it is water soluble. Now there are no adverse kind of antigen antibody reactions associated with this particular type of material, either in the cortical site or in the medullary cavity or at the surrounding tissues. So with the use of this conventional bone wax, foreign body responses are very common, as we have discussed about the granuloma, right. But with this newer material there are no such disadvantages. Further, the bone wax also gets displaced within the bone marrow, and it can also affect the bone ingrowth within those defects, so it can stimulate ingrowth of the bone. Whereas as this is a water soluble kind of a material, it has an edge over the traditional materials, that is bone wax. So it shows no adverse tissue response, and it also does not interfere with the healing at that site, that is bone healing. So again, very good material. When we have to control bleeding from the bone, we can use osteo there instead of bone wax. Moving on towards the last method to achieve hemostasis, that is by use of certain thermal agents. So basically this thermal agent act by coagulating the blood and by sealing off those blood vessels, right, and therefore it is providing us a bloodless field during the surgery. So if at all the agents which are used to achieve hemostasis under this thermal methods, if not used carefully, this can lead to various lesions like hemangiomas, right, and can also lead to a large amount of intraoperative bleeding. So whenever we are employing this thermal method to achieve hemostasis, we should be very careful, as it is a double-edged sword. So under thermal agent, first we have electrocautery, also known as surgical diathermy. So again, this is a very routinely used method to achieve hemostasis, right, in surgical procedures. So basically it uses a very high frequency current, and a high frequency current is applied to the specific area, right, wherever we want to remove the tissue. And whenever this thing is used, it will serve two purposes, right, it will remove the tissue, it will aid in visualization of the deeper structures by doing so, and also simultaneously it will coagulate the blood vessels as well, right. So it is creating a surgical incision, as well as it is aiding us in coagulation. So the frequency of the current which we are using is between 1 to 3 millihertz, right. Next up we have cryosurgery. So basically it is a process wherein we are rapidly freezing the tissues by exposing those tissues to intensely lower temperatures. So this method usually implies uses of a probe, wherein the probe contains liquid nitrogen, right. So basically this cryosurgery or using the cryoprobe is not an ideal coagulation method, right, but at all if we have to undergo or minimize the amount of dissection of the tissue planes which we routinely need to do during surgical procedures, or extensive incisions if we need not have to employ, in that cases we can use this method, right. It is very easy, a cryoprobe is there, and we can directly use this probe over the affected side, and we can achieve hemostasis. Lastly we have lasers, right. So lasers help in coagulation of smaller blood vessels. Nowadays this is a very common modality, and various different surgical processes are we are undergoing with the help of lasers. Why? Because again the same thing, we are getting a very good surgical incision, precise one, and simultaneously it is also aiding in coagulation. So one laser tip can serve two purposes at the same time, right. Also it is comparatively minimally invasive procedure as compared to our routine surgical procedures which we do with the help of our forceps and elevators, right. So with this laser procedure, as you can see here, right, the patient has underwent extraction, and then we are using the laser, it is a diode laser, to coagulate the extraction site to arrest the bleeding. So again, a very commonly used thing nowadays. So laser is also a good method to achieve hemostasis, provided that the operator is well versed with the technique of handling the lasers. If not, then definitely it might lead to various mishaps. So before using this thermal agent specifically, be it electrocautery or a cryoprobe or a laser, the operator needs to be well versed with the method or the directions of use of that particular thing. Only then we can have an advantage. Otherwise, unnecessarily it will lead to various hemangiomas, and also it might lead to excessive bleeding if at all it is employed at the wrong side. And especially during the uses of lasers, we have to be careful that there are no mirrors incident on that light, otherwise again it will get refracted and cause hazards. So this was all about various methods to achieve hemostasis. I hope you enjoyed this video, and if you feel so, do not forget to like, share and subscribe to my channel. Till then, this is me, Dr. Snail, signing off. Bye bye, take care.